I'm Lebogang, still with you on the Business Hour. We've been looking at the business of medicine from a solutions standpoint. Now, the Universal Healthcare Access Coalition tells us that national healthcare insurance is not feasible. It's unfeasible and it's unworkable. And they, in fact, want to propose an alternative. What is that alternative, you may be wondering? Well, we're hearing from Professor Alex van der Heever from the Universal Healthcare Access Coalition Steering Committee, and he's in conversation with my colleague Zenande Mpame about this.
What is the core principles of the Universal Healthcare Access Coalition about, and how does it differ from the NHI Act in terms of funding, governance and service delivery?
The proposals focus on reforming the system as it exists, and the fundamental principle or guiding principle is that the universal healthcare coverage model that South Africa pursues has to combine both a tax-funded component and what's called a contributory component, where people contribute toward their own coverage. And that is the only way in which we will achieve universal coverage. It is not possible to have a single scheme cover the entire country for an adequate benefit using just tax money alone. So once you've accepted that you've got to combine the contributory system and the tax-based, the free public healthcare services as the overall regime, then you have to look at the designs that flow from that. So the recommendations in this policy framework flow from the reality that we have to have a combined contributory and tax-funded system. And what it then looks at is how to correct the governance weaknesses of the public system that are resulting in systemic failure, correct the regulatory and structural features of the private system that are also causing systemic cost increases and also reduction of value for money for people who covered there. And those recommendations flow from the Health Market Inquiry, which completed its work in 2019, and a number of prior inquiries. So this is the overall sort of logic that flows from this. The National Health Insurance proposals assume that you can fund the entire universal coverage framework through taxes, which is not possible. And it also requires, for it to be implemented, to essentially collapse the provincial health system as it stands and to collapse the medical scheme system as it stands and consolidate everything into a single fund. And this is just institutionally reckless in the South African context. The further problem that flows from the NHI proposals is that they are not viable, they're not implementable in any realizable time period or ever, really. And the problem is that people are then saying in government that they're implementing a reform in the health system, but actually reforming nothing. So the status quo is actually just going to remain indefinitely into the future unless there is a focus on what needs to happen.
The UHAC argues that the NHA is unimplementable and fiscally unsustainable. What are the biggest flaws in the NHI Act, and why do you believe your framework offers a more viable alternative?
Well, it is, first of all, it doesn't strain the fiscus. It is implementable in a manner that is consistent with available resources. It also allows the sort of higher income or people with sustainable incomes to be covered. They are responsible for paying taxes that fund the public system, and they're also responsible for paying for their own coverage. So they effectively pay twice. And you want to maintain that system because it actually leverages coverage much better than if you attempted to raise taxes only for one system. The public system requires a fundamental governance change, not an architectural change. The governance change is to actually separate the political actors, the people who are in political positions, the members of the executive, from the administrations and the running of the health services themselves. So it proposes sort of two features to that. One, it says a lot of the public health system needs to be run as autonomous organizations like public hospitals where the CEO has complete control over what they're doing in that hospital. But the danger with that is that there's the possibility of corruption, etc., which is why you have to have supervisory boards that oversee the public hospitals and the proposed district health authority system. And those people appointed into those boards are not appointed by politicians. There's a separate appointing authority that's independent again of the executive of government that will vet and appoint people into those structures and hold the CEOs to account. So the public system is then cleaned up by not allowing political actors to essentially deploy networks of extraction into the public system, which is why it's failing at the moment. And the private sector really requires a number of interventions to change behavior in the system, to modify it from competing on demographics and competing on the risk profile of their members, and competing instead on the cost and quality of the healthcare they're covering. And that requires that the reform frameworks proposed in the Health Market Inquiry are introduced as a major systemic reform.
Jy luister na die OFM Sake Uur met Olebogeng.
I'm going to pause Ananda's conversation with Professor Alex van den Heever here. He's from the Universal Healthcare Access Coalition Steering Committee. What are your thoughts on their alternative to the NHI, which is from the Universal Healthcare Access Coalition? You can telegram us 0842229497. Fiscally sustainable, they say it is. There's still part 2 of that discussion coming up shortly. Still looking at the business of medicine with Professor Alex van den Heever from the Universal Healthcare Access Coalition Steering Committee. They say that they're offering an alternative to the NHI, which they say is fiscally, it's not sustainable, it's fiscally dysfunctional, essentially, and they are offering an alternative. He's in conversation with my colleague Zinande Mbame about their alternative.
Model, combining medical scheme contributions and general taxes. How would this work in practice, and how does it ensure affordability and sustainability?
So we have a version of that in place at the moment. The problem is that the two parts of the system are not actually regulated or governed adequately. So basically, if the governance frameworks are deepened on both sides, the systems will work much more efficiently. In the public sector, the productivity will improve considerably if the governance and the governance structures and accountability structures and systems are introduced. In the private sector side, the issue is that the cost increases are creating a coverage problem that might not materialize fully now, but over time can become problematic from a coverage perspective. So the private system needs to be structured in such a way that there are strong incentives to purchase healthcare services on a value for money basis, in which they look at both cost and quality. That requires the introduction of what's in the Health Market Inquiry, the risk equalization scheme, the social insurance systems, which mean that they underwrite schemes in such a way that they are pooled at the level of the system and not at the individual scheme level. And by doing that, they can accept any demographic group without risk, and therefore they have to compete by differentiating their offerings based on real value, not on superficial value. So these, without going into the extensive detail, it's a fundamental shift in emphasis as to how the private sector operates. And as part of this overall framework, it is to actually run it, regulate it, and have the the pooling systems operate in such a way that there's also harmony between the public and the private systems. So if somebody's covered in a medical scheme and they want to use, and public hospitals improve the quality of what they're providing, people on medical schemes can choose to use a public facility, and that public facility will receive funding from medical schemes for services that are rendered. So in the NHI proposals, they presume to increase taxes in order to add money from the medical scheme members and put that into the state pocket. In this arrangement, it doesn't propose to do that. It says that medical scheme members can use the state system, but they will pay for it through their medical scheme. So essentially, you don't have to introduce a tax in order for the state to be remunerated. But it is these arrangements, which are very viable and have equivalents around the world, that allow for a degree of harmonization between the two systems. And over time, we would basically be able to deepen our coverage, because our costs would become more affordable on the medical scheme side, and the state will improve its funding over time through economic growth, but its productivity of spend will also improve dramatically.
Jy luister na die OFM Sake Uur met Olebogeng.
That wraps up the OFM Business Hour for this evening. Thank you so much for tuning in. A big thank you to my colleague Zinande for helping me out with those conversations. And like I said, a big thank you to our guests. Aubrey Larkins gave us that